Thank you, Sarah, for joining us today. Hello, everyone. Welcome to IPC Club session 39. And we have Professor Sarah Tschudin Sutter from Basel, Switzerland. Professor Sarah is a board certified internal medicine and infectious diseases specialist, and her main research interest is in the transmission of hospital acquired infections and also C. difficile infections. She conducted a medical training at the University Hospital Basel, Switzerland, and obtained her Masters of Science in Infectious Diseases and Epidemiology, as well as board certificate in Healthcare Epidemiology at Johns Hopkins Bloomberg School of Public Health. Sarah, you can start with your talk, please. Thank you.
Thank you very much. Thanks a lot, Kalis, for your very kind introduction, and thanks also for inviting me to give this presentation. So, as mentioned, I will be speaking about respiratory viruses and how to prepare the next winter season. So, I'm not sure what it's like in your part of the world, but here we are actually quite happy that spring is seeming to start. So it may be a little strange to speak already about the next winter season, but we are all aware that it's important to prepare well in time. So within the following presentation, I would like to outline how some of our thinking about prevention of respiratory viruses has changed since the pandemic, then speak about differences between the respiratory viruses, which are mainly concerning us in healthcare settings, and to discuss basically if it makes sense to have different infection prevention and control strategies targeting different respiratory viruses, or if we should aim to unify our infection prevention and control recommendations. And then I will, of course, go over the most important recommendations for infection prevention and control. And in addition to what's being discussed in the international literature and also guidelines, I would like to try to share some of our experience here in Switzerland. So to start, what has changed since the pandemic? And I think we are all aware that it is mainly our knowledge on transmission routes, the traditional dichotomy of describing transmission of respiratory viruses as occurring by aerosols or droplets has been left, and we have learned a lot more during the pandemic and are moving to a different understanding. And this has been discussed, of course, also within the World Health Organization, where this global technical consultation report has tried to find a new terminology for pathogens that transmit through the air, a complicated and complex process which involves many representatives of different professional groups. So what this expert panel came up with is the term infectious respiratory particles, which exist in a wide range of sizes, from submicrons to millimeters in diameter. And these emitted infectious respiratory particles are exhaled as a puff cloud, traveling first independently from air currents and then dispersed and diluted further by background air movement in the room. So infectious respiratory particles exist on a continuous spectrum of sizes, and no single cutoff point should be applied to distinguish smaller from larger particles. And this terminology allows to move away from the dichotomy of previous terms, such as aerosols, generally smaller particles, and droplets, generally larger particles. The expert panel moves on to describe the modes of transmission within this framework and proposes the modes of airborne transmission, transmission by inhalation, or transmission occurring by direct deposition. The typical distance from the source for airborne transmission may occur at any distance. For direct deposition, the distance is short. And the entry of the respiratory tract by which infection may occur is inhalation for airborne transmission, where it is deposition on the mucosa for direct deposition. So this kind of sounds quite logical and also reasonable, but what does it mean for everyday practice in infection prevention and control? And this is where the expert panel did not or was not able to make any further recommendations. However, the experts could unify on some general principles, which are that there is no suggestion from this consultative process that to mitigate the risk of short-range airborne transmission, full airborne precautions, as they are currently known, should be used in all settings for all pathogens and by persons with any infection and disease risk levels. Additionally, the new term of direct deposition may be similar to the existing term of droplet transmission mode, but without any specific particle size designation. While further understanding of this form of transmission is elucidated for pathogens suspected or known to transmit via this mode, the existing droplet precaution should continue to be used to prevent direct deposition of respiratory particles. But personnel may still be vulnerable to infection via airborne transmission, inhalation if the pathogen can also transmit via this mode. Similarly, for transmission via contact mode, existing precaution known as contact precautions should continue to be used. And the experts, they end this report mentioning that many diverse disciplines will be need to brought together in order to design specific infection prevention and control measures based on this new terminology and framework. So moving on to the practical implications, I think we can agree that transmission pathways alone are not sufficient to indicate which mitigation strategies are to be chosen. And these preventive measures should also depend on the pathogen and its virulence, treatment options available, morbidity and mortality of respective infection, the patient population we are trying to protect, and also the institution. So perhaps we can agree that pathogen and setting-specific guidance regarding mitigation measures, including infection prevention and control guidance, is needed. So this brings us, I think, to the question if we still should consider differences between respiratory viruses and tailor our infection prevention and control strategies towards different viruses, or if we should try to unify our IPC measures. And to open up this discussion, I would like to show the results of this systematic review, which was published in Nature Reviews Microbiology in 2021, trying to summarize the current knowledge on transmissibility of different respiratory viruses. And what we can see here above is the coronaviruses, not including SARS coronavirus 2, then influenza viruses and RSV among the other respiratory viruses, but these are the three I would like to highlight. And we can see the basic reproductive number and the household secondary attack rate. And what you can see is that these numbers are actually quite similar across these different respiratory viruses. So the basic reproduction number being estimated as between 0.5 to 8 for coronaviruses, between 1 to up to 21 for influenza virus, and between 1 and 22 for RSV. And again, the secondary attack rates, a wide range being reported in the literature, but being reported as between 38% for coronaviruses, for influenza virus, and for RSV. So quite a large similarity in these terms for these three respiratory viruses. Then in terms of evidence for direct contact transmission, again, there is literature supporting this mode of transmission for all of these respiratory viruses, the three we are mainly concerned about in healthcare settings. And then in terms of indirect contact or fomite transmission, again, we can see evidence for this transmission mode playing a role for all these 3 respiratory viruses. So this brings us to the question of severity and long-term mortality and the comparisons between the 3 respiratory viruses, which I believe are most troubling in healthcare settings: COVID-19, influenza, and RSV. And I would like to point to the results of this systematic review, which was performed in JAMA Internal Medicine, I apologize, this was not a systematic review, this was a study performed in the US, looking into the Veterans Affairs healthcare system and summarizing the data on outcomes for infections with these 3 different respiratory viruses. And what we can see here are comparisons between the 2022-2023 season in terms of RSV and influenza. This is on the left side of the figure I am showing, then death during the same season, and then also looking into outcomes such as hospitalization, ICU admissions, and death for the 2023-2024 season. And what we can appreciate is in the comparison between RSV and influenza, we don't see any significant differences for the season 2022-2023. We see a difference in the next season for influenza, resulting in more hospitalizations, but no differences in terms of mortality. Then the comparisons between COVID-19 and influenza on the right-hand side of the figure. Here we can see that for the 2022-2023 season, we do have differences showing that COVID-19 may be more severe in terms of hospitalizations, in terms of ICU admission and death. But then when we look at the season 2023-2024, we can recognize that these differences are becoming less distinct, so moving to no significant differences. And then looking at the comparisons between RSV infection and COVID-19 infection, we can see here again the 2 seasons, 2022-23, 23-24. And again, we can appreciate that the outcome of death seems to be losing its significance in differences between infections with the 2 respiratory viruses. So with this, I would like to share some of our experience in Switzerland. And this was a comparison between the outcomes, again, death and also discharge alive data shown here, between COVID-19 infections and influenza infections. And this was mainly the Omicron variant, which was studied within the context of this study. And what we can again appreciate if we look at the 2 lines, so showing death by the full line on the bottom, and then discharge data, we can see that actually the 2 viruses are not significantly different in terms of both outcomes investigated here. So in summary, these studies seem to be suggesting that the outcomes of infection with these 3 respiratory viruses seem to be becoming more and more similar. So I would like to highlight the data which was presented within this study published in Clinical Infectious Diseases in 2023 by colleagues in the US, and looking into the number of hospital onset infections for influenza and for RSV, and showing also the number of hospital onset cases as compared over the time frame from 2015 to 2023. And what they noticed is, I guess, the same that we noticed in many healthcare settings, is that, of course, the interventions such as masking, screening patients and visitors for symptoms, they were associated with a distinct reduction of around 50% in hospital onset influenza and RSV. Also here, trying to account for changes in the community incidence. So another piece in the puzzle showing us that these viruses may not only be behaving similarly in terms of transmissibility, attack rates, and also morbidity and mortality, but they are also responding to similar infection prevention and control interventions. And this brings us to the specific recommendations for infection prevention and control in order to target these free respiratory viruses. And I would like to start this part of my presentation highlighting the findings of this review article, pointing to some, I think, important key messages that nosocomial respiratory viral infection rates mirror viral activity levels in the surrounding community. So we may want to consider to implement IPC strategies also corresponding to community incidence, that the burden of hospital-acquired respiratory viral infection is high, estimated here in this review at around 15 to 20%, and that practical strategies to prevent nosocomial respiratory viral infections should include maximizing staff and patient influenza and SARS coronavirus 2 vaccination rates, and implementing routine masking during patient interaction, especially when community incidence is high. And this brings me to the recommendations targeting all three respiratory viruses, SARS coronavirus 2, influenza, and RSV, in a unified manner by the European Centers for Disease Control and Prevention. And I would like to run through this guideline, which I feel provides a useful and important framework for our IPC strategies. And these include administrative measures to be taken by the hospital, such as concepts for triage, initial contact and assessment, then testing, adherence to standard precautions, which I think we are all aware working in IPC, how important they are all the time and everywhere. Then transmission-based precautions targeting respiratory viruses, measures to be taken for healthcare workers, and also environmental cleaning and disinfection, as well as ventilation. So the administrative measures which are highlighted within this document include triage, initial contact, and assessment, including providing information regarding respiratory symptoms and the need to follow respiratory etiquette for both patients, healthcare workers, and I should also add visitors whenever these symptoms are present. Then to provide knowledge on the epidemiological situation and primary care staff within healthcare settings, and to assure the availability of masks and alcohol-based hand drops, for example, in all our entrances of the hospitals, but of course also on the wards, to make sure these are really readily available. Testing strategies. So here the guidelines highlight the need for early detection, rapid testing of symptomatic patients, which I believe is a cornerstone to prevention strategies, testing of contacts of patients who are infected with either of the respiratory viruses and have been exposed. I think this is an important measure to mitigate onward transmission during hospital stays, especially if we are working in hospitals with shared patient rooms. And then a little more controversial, the topic of universal admission screening, which was performed widely, I believe, in many hospital settings during the pandemic, but its role being less clear now after the pandemic. And we will look into some of these recommendations Here, a commentary regarding universal screening, which was published by our colleagues from the US, mentioning that there are many drawbacks to systematic asymptomatic screening here for SARS coronaviruses. And some of the challenges which they highlight by implementing such strategies are, of course, the strains on resources for testing, for laboratory resources, but also on all the healthcare workers needed to collect such specimens. The fact of unnecessary isolation of non-infectious patients, so many patients detected by these tests, which may be at the end of their infection and not having high viral load. Then even initiation of inappropriate antiviral treatment, prolonged length of hospital stay, then also the strains on our bed availabilities, delayed medical care, the costs involved and the inconvenience for patients, and also the sense which we provide to healthcare workers in terms of a false security if a screening result is negative. So this expert panel recommends against routine universal use of asymptomatic screening here for SARS coronavirus 2 in healthcare settings, but highlights that such a strategy may be useful in times of increased virus transmission in some specific settings, perhaps also in settings with shared patient rooms or behavioral health congregate care being required. So I would like to share our experience in terms of asymptomatic screening for SARS coronavirus 2 in our healthcare settings, where we also performed a lot of screening tests. In fact, during the course of the pandemic, over 75,000 screening tests were performed on asymptomatic patients. And our results found during the entire period that we had 761 patients and providing approximately 900 positive tests. And when we looked at all of these 900 positive tests, which accounted for 1.2% of all screened patients, then the proportion of false positive tests was strikingly high at 36.5%. And indeed, this did lead to unnecessary isolation in 50% of the patients with false positive tests, exposure then to true positive COVID patients by cohorting them in the same wards, and also resulted in delayed interventions in 3.2% of our patients. What we also were able to see was that test positivity did correlate with the local incidence as shown in the figure. And we do have wastewater monitoring set up in our city. So we also could see a correlation with the wastewater viral load. So for us, the conclusion was that universal SARS coronavirus 2 screening may detect asymptomatic carriers. It does align with community incidence and may be of support for IPC measures aiming to control nosocomial transmission. However, the resource demands and unintended consequences, and particularly during times of low incidence, would really necessitate careful contextual implementation. And currently, we have abandoned systematic screening of asymptomatic patients, with the exception of patients who are admitted to our stem cell transplant units. So just showing an example where we do feel that this risk-benefit ratio is on the side of performing such screening. So in terms of adherence to standard precautions, I think we are all very well aware, working in IPC, that this remains an ongoing challenge. I believe in terms of prevention of respiratory tract infection, the thing we can do is to highlight the importance of standard precaution measures also for prevention of respiratory viruses. And the data I am showing here is just showing that our adherence to standard precautions is really low. We believe that we are better than what is really observed, and this distinction is shown here. The gray bars showing the self-reported adherence and the actually observed adherence being much lower. So making healthcare workers continuously aware of the necessity to follow standard precautions, I guess, is one of our main challenges. Moving on to transmission-based precautions, I wanted to highlight some of the recommendations by different international societies, such as the CDC. Here also shown the recommendations by the Robert Koch Institute. And what we can appreciate from these tables is that these recommendations are actually quite different for the different respiratory viruses. And I think after the pandemic, where we are seeing circulation of all 3 respiratory viruses, this makes it extremely challenging for healthcare workers to follow and to understand when to apply which different item of the personal protective equipment, depending on the respiratory virus a patient is infected with. So the ECDC guidelines actually make the step of proposing a unified framework also for transmission-based precautions for these 3 main respiratory viruses. And what they recommend is something which I feel is like a bit of a policy shift for many IPC strategies, which mentions targeting IPC measures determined on the activities we are actually performing within an isolated patient room. So the recommendation being that it is recommended that healthcare workers interacting with patients who have viral respiratory infections without close proximity or long exposure to the patient should wear a medical face mask as a minimum, but then for prolonged contact in close proximity to the patient, including performance of high-risk procedures, a well-fitted respirator and eye protection are recommended. Then, in terms of the use of gloves and gowns, they are recommended for use if there is any risk of exposure to bodily fluids, but are not part of the standard protective equipment used to just enter a patient room. So this brings us, I guess, to the discussion which we are all very familiar with in terms of which type of mask should be used for protection against respiratory virus infection. And I would like to highlight the Cochrane review, which you can see here, comparing the data on the efficacy of N95 masks and as compared to surgical masks for protection against respiratory virus infection. And this review came to the conclusion that the use of N95 respirators, compared to medical surgical masks probably makes little or no difference for the objective and more precise outcome of laboratory confirmed influenza infections. Harms were poorly measured, but the authors do also highlight that it may be challenging to wear N95 masks for a longer duration of time period. And this is, of course, data mainly derived from influenza as a target viral pathogens. And then I think we are also all well aware of this randomized trial which was performed looking into differences between the use of N95 respirators for preventing COVID-19 infections as compared to medical masks. Multi-center randomized controlled trial involving centers in Canada, Israel, Pakistan, and Egypt. And here the conclusion was that in routine care of COVID-19 patients, N95 masks may offer minimal additional protection as compared to medical masks. And of course, here any aerosol generating procedures were excluded, whatever that term may mean. So I would be really happy to discuss perhaps afterwards how you are managing this in your healthcare settings. What we have tried to apply in our institution is that, and that is what is in line with the ECDC recommendations, is to have the recommendation of the use of medical surgical masks when entering the room of a patient with respiratory virus infection, but to use N95 respirators or FFP masks in our case whenever procedures are performed in close contact to the airway of the patient. Also, prolonged exposures are to be expected, or of course when any aerosol generating procedures are performed. With this, I would like to also share some experience from our healthcare setting, looking into the issue we had during the pandemic, but which I think we always are also struggling with during times of high endemicity of any of the respiratory viruses, which is the one of not having enough single rooms or isolation rooms available during peaks of respiratory virus infections. And we struggled with this during the pandemic, especially in the setting where we were not yet aware if a patient was infected or not with SARS coronavirus 2, while results were still pending. And here we had this strategy of isolating patients with suspected COVID-19 in multi-bed rooms, however, trying to isolate them on site. And we compared the secondary attack rates or the forward transmission rates in these patient rooms between these strategies. And what we actually found was that when we isolated patients with suspected COVID-19 disease in multi-bed rooms on site, then we had actually a zero secondary attack rate over, of course, a short time period of just a couple of hours. So we believe that this on-site isolation strategy may be useful to cover short time periods. I'll also be interested to hear what your experiences are and how you are able to manage this period until the test result is actually available. So moving forward along the ECDC recommendations, of course, healthcare workers should perform hand hygiene, the use of medical face masks as part of a universal masking policy is advocated, especially during phases of high endemicity. And they also highlight the importance of staff members with symptoms compatible with respiratory virus infection, that they should be relieved from clinical duties and also allowed to stay at home when being sick. And then, of course, also the need for vaccination against influenza and SARS coronavirus 2 in accordance to national recommendations. And in terms of the efficacy of the COVID-19 vaccine to prevent ongoing transmission, I would like to show the results of this study performed or published in 2022, and showing the differences in the prevalence of COVID-19 resident cases according to the staff vaccination rate in different facilities. And what we can see here in blue are facilities with high vaccination rates as compared to in red facilities with a low vaccination rate. And this does in fact translate to differences in cases among who are hospitalized. So I think it is important to highlight that also for COVID-19, the vaccination does provide protection against ongoing transmission. And then also data highlighting the same point, just a very different setting. This is a California prison setting, showing that both the number of COVID-19 vaccine doses received and prior SARS coronavirus 2 infection of index cases reduces the risk of virus transmission to close contacts. And I think this data is quite important to highlight because also during the pandemic, of course, there was some disappointment that the vaccine does not completely, of course, avoid infection, but has, of course, its main effect in avoiding severe disease. So I think this data also showing its effect on onward transmission is quite important and useful. And this would bring me to the topic of environmental cleaning and disinfection, which was quite excessively done. I think in many institutions, this here shows a picture of our institution during the pandemic. And we have moved to quite comprehensive cleaning and disinfection protocols for patient rooms, to disinfecting frequently touched surfaces. So while transmission by contaminated surfaces, I think, still may play a role, I believe we have probably all learned to appreciate that this may be not quite as important as other transmission pathways and probably mainly confined to the potential for transmission from high-touch surfaces in patient surroundings. And this would bring me to the topic of ventilation, where the WHO recommends at least 6 air changes per hour in regular patient rooms. And of course, this has also been very widely discussed during the pandemic. This may be achieved by natural or mechanical ventilation. And then in addition, air filtration and ultraviolet germicidal irradiation may be complementary approaches in healthcare settings. The take-home message here is that increasing air changes and also ultraviolet irradiation and portable HEPA filters may decrease transmission rates, but their marginal benefit relative to current healthcare ventilation standards has not yet been established. And again, I'd be interested to hear how you managed this in your healthcare settings during the pandemic. We actually invested an awful lot in these HEPA filter, portable HEPA filter devices, and have largely abandoned them at this point in time. There is little data, to the best of my knowledge, still available. Looking into the effect of additional air filtration for preventing respiratory virus infection. This is a study which looked into the implementation of such air filtration devices over time. And what they were able to show here in this quasi-experimental controlled before-after study was that implementation showed a trend towards a lower hazard for SARS coronavirus 2 infection, which, however, did not reach statistical significance. And I think we are all aware about the challenges of implementing such a strategy, looking into the entire maintenance, but then also patients, at least in our setting, being very much disturbed by the noise, which was also done by these devices. So I think in essence, what we do need to prevent respiratory virus transmission in our healthcare settings is what we always need in IPC, which is this Swiss cheese model, hoping that each additional layer of IPC measures will contribute to preventing respiratory virus transmission. And with this, I would like to thank you very much for your attention, and I'm really happy also for your questions and to learn from your experiences and for some discussion. So thank you very much.